eating my lunch, which included some carrots, and a little piece of carrot just kind of landed in there. So it'll be irritating me throughout the lecture. My apologies for that. Try to minimize choking and stuff as much as I can. So we have been talking then about the stages of labor, and this is a slide that we did see before, but I thought I'd start with this one and just review second stage, third stage. Second stage is expulsion. Third stage is the placental. So the term expulsion, when used to describe a stage, is referring to the second stage, and it is the fetus that is being expelled at that time. The third stage, of course, does also include expulsion, but it is of the placenta and the fetal membranes. So we recall this image of the delivery stage, the stage 2, and then this, the stage 3, so expulsion and placental stage. And we had talked about the fourth stage, final stage, where there's recovery. So the continued uterine contractions, we had stated that sometimes the physicians will, the obstetricians will administer oxytocin, or Pertocin, as it is called clinically. And this will increase these uterine contractions to minimize risk of hemorrhage. The spiral arteries, as we know, are ruptured as the decidua basalis was removed or expelled. And this can last for a few hours, so it's important to have that protection. The which stage of the labor is the afterbirth expelled? Excuse me. So that is the placental stage, stage 3. Which hormone is not produced by the placenta? Placental lactogen, human chorionic thyrotropin, relaxin, and inhibin. The inhibin was the one on this list that we did not see in any prior slide. Inhibin is not produced by the placenta, but these others we did see the relaxin to relax the pubic symphysis and allow expansion of the pelvic outlet, the bony pelvis. The human chorionic thyrotropin, there were several hormones, thyrotropin, adrenocorticotropin, and so forth, and the lactogen that are produced by the placenta. So during the, which stage of labor is the fetus delivered? That is the expulsion, the T shouldn't be there, sorry, the expulsion stage. So in seeing these questions, obviously exam questions, it brings to my attention that I received a phone call just before getting here, but also the problem that emerged or arose over the weekend. I want to thank Marco for being attentive and logging on and catching the problem and corresponding with the student that brought it to his attention and with me, and for fixing it. But he reset the exam to end at noon today, I think it was, and I know I had originally said midnight. I was very busy on the weekend doing a report that was due today for the college. I didn't get a chance to follow up on that. After class, I'll reset it through midnight tonight for those of you that didn't get a chance to take it the second time. The problem that we had was when I reset the exam, it has an indicator of how many times you let people take the exam. I left it at 1 because I was resetting it. I thought that as a reset, you'd have one more chance to do it. But it isn't one more chance it was measuring. It was how many chances total, how many attempts total. So it had to be increased to 2. And fortunately, Marco discovered that and got it going. So my apologies for the confusion. Still learning this system as we go along.
Dr. Felix, I just updated the exam to run until midnight.
Oh, thank you very much.
It's done.
Yeah, see, I don't need to do things. That's what he's getting paid for. That's you in the front there, Nayeli?
Yes, it's me.
You better use the microphone. All these years of training as an SI. Welcome aboard. So back to the lecture then. The maternal surface of the placenta has a cobblestone appearance. So this is where the interaction, actually I think we did this slide as well. Sorry about that. But just the same, we'll push through it. So the chorionic villi create the cotyledons with the space, the grooves in it, intervillous space. So the obstetrician will examine the placenta very carefully and closely after the expulsion phase, and as well it is taken to the path lab for evaluation. So the excessive attachment of the chorionic villi to the endometrial lining can cause the excessive bleeding during the third trimester or at delivery, and this produces a condition. I guess we didn't get to this, sorry. I'm a sorry son of a gun today. The placenta accreta or placenta percreta are terms that refer to these two situations. And we said there are a variety of things that can occur to alter the interface between the placenta, the fetal side and the maternal side of the placenta, and these have implications for the remainder of the pregnancy. So here we're seeing figure number 716 from the textbook, showing some of these types of anomalies or abnormalities of the placenta. So in the placenta accreta, there's abnormal adherence of the placenta to the myometrium. So it actually is, where is it, accreta over here. So there's actually an infiltration deep enough into the myometrium. In the placenta percreta, it penetrates the full thickness of the myometrium. So this obviously is not a nice thing to have happen. So any type of infiltrative cellular hyperplasia activity, as we see here, is not really very good. So tumors have this type of characteristic. They can spread within an organ from tissue compartment to tissue compartment. We see this is occurring here. So it's not the normal situation. It's a relatively aggressive type of placental development. Anytime you get the uncontrolled infiltration, hyperplasia, crossing tissues within an organ, it's not going to be a very pleasant situation. Placenta previa is the one that we had mentioned, where it's otherwise a relatively normal placenta as far as infiltration into the endometrium. But here it is between, or at least it covers the internal os. There can be different portions. It can be a complete placenta previa or incomplete, but it is between the amnion, the smooth chorion, and the decidua parietalis, capsularis. That layer that we defined, that should be the only barrier with the internal os. The placenta will be between that barrier and the internal os, and very likely to tear first as the cervix is dilating and you get hemorrhage before delivery. Not a good situation. So the maternal surface, continued improper placement of implantation may cause the placenta to block the birth canal, therefore the placenta previa being presented first. So this is extremely dangerous and quite often leads to a cesarean section. The fetal surface will be smooth surface because of the amnion. And then we come to this slide to see a ultrasound showing certain of these structures. So this is an ultrasound view. It's quite a characteristic way of presenting it. It shows placental abruption. So the dark spot, it is marked. The dark spot is where the placenta is pulled away from the wall of the uterus. So this is not a good situation within the pregnancy, because where it does pull away, there will be hemorrhage into that area and blood clots and a variety of tissue reactions to that type of a thing. Now we have a case study, a 25-year-old G2. Anybody want to tell us what that is? Gravid twice, the second pregnancy. Then the P and the A, one. Who knows what that is? But some type of notation that the white female was referred to the perinatologist for evaluation of an abnormal ultrasound and persistent vaginal bleeding during the second trimester of her pregnancy. The patient had a gestational age of 21 weeks based upon the last period. And the patient was noted on ultrasound to have a 10.2 by 6.9 centimeter multicystic mass in the lower uterine segment, which bulged into the amniotic cavity, as well as enlarged ovaries bilaterally. So above the intrauterine mass, a normal appearing gestation with the fetus measuring consistent with the 21 weeks. Patient had intermittent nausea and vomiting, as well as almost daily painless vaginal bleeding, but was otherwise without complaints. So the patient's obstetrical history was significant only for a spontaneous miscarriage at 2 months, which was followed by a D&C. She had no prior history of bleeding disorders, abnormal pap smears, or STDs. Patient had no other significant medical or surgical history, and then that ultrasound image we saw was revealing this. So we included this so that we can see we are almost prepared enough to review this and understand everything that it is saying. It obviously was not a very good situation. It led to termination of the pregnancy. So here we're looking at the lower uterine segment in this case, and we're seeing the demarcation of the normal gestation, that one. And then the cord insertion of the fetus is shown here with a mass adjacent to the amniotic cavity. So here's the cord attachment to the fetus. We're just seeing a piece of that. Then the amniotic cavity here and some kind of a mass. Then we can see the enlarged ovary measuring about 7 centimeters, so there's definitely something really bad going on with the ovaries, some type of cystic formation. So on physical exam, the patient was afebrile, had no fever, had stable vital signs, abdomen was soft, non-tender, non-distended, gravid, with a fundal height of 26 centimeters. The cervix was long and closed. Quantitative DHCG was quite high. So this was based on those findings. Highest on your differential diagnosis is one of these 4 possible choices. Complete placenta previa, gestational trophoblastic disease, twin-twin transfusion syndrome, pneumocystis carinii utericus. So we would have to try to choose which those would be. So it is not obviously placenta previa. It's found in the lower uterine segment. So our lower uterine segment did not show the placenta present there. Covers the cervical os like a mass. Placenta can actually be seen in the posterior surface of the uterus through these images. And the mass covering the lower uterine segment has multiple small cyst structures that are not consistent with the appearance of placental tissue on the ultrasound examination. while placenta previa would account for the vaginal bleeding, it would not account for the enlarged ovaries and the extremely elevated HCG. So we can see that I've included this very advanced clinical case in terminology to make the point of placenta previa and the clinical presentation of it, which of course would not be what we see in this case. This is the mass with the cysts contained inside of it. So try a second choice. Good answer. Gestational trophoblastic disease is divided into molar pregnancies and gestational trophoblastic tumors. Molar ones are characterized histologically by abnormalities of the chorionic villi, various degrees of trophoblastic proliferation, and edema of the villus stroma. Obviously, I'm not asking you to become a pathology expert. This is included to make the point about it not being placenta previa, so we understand placenta previa a bit better. Presence or absence of a fetus in the gestational trophoblastic disease or embryo has been used to classify them as partial or complete moles. In a complete mole, the chorionic villi are converted into clear vesicles and often hang in clusters from thin pedicles. Chromosomes of complete moles most often are 46XX, completely of paternal origin. So we can see this is a case of the placenta gone wild and doing things that it's not supposed to do. So it typically happens when a haploid sperm fertilizes an ovum and duplicates its own chromosomes after meiosis. Thus, the chromosomes are homozygous. So occasionally, as in the case, the chromosomes may be 46XY, which is due to a dispermic fertilization. Even though we said polyspermy doesn't happen under normal conditions, yes, it does not happen. But when it does happen and things are going wrong, there can be strange outcomes. On partial moles, the changes are focal and less advanced than a fetus or at least an amniotic sac can be found. The karyotype typically is triploid, 69 XXX or XXY or XYY, usually with one maternal and two paternal haploid complements. So there's a variety of aberrations. Some of them can be induced by the multiples of the genome being represented. So the fetus of a partial mole typically has stigmata of triploidy, which includes multiple gestation, congenital malformations, growth restriction, and typically is non-viable. So as in this case, a twin gestation may occur with a complete mole and a normal fetus. So the structure that was vesiculated, the mass that they kept talking about, was a twin gestation, but of course it was a mole and not a fetus. So below is a photo of the normal placenta, which occupied the upper part of the uterus, as well as the molar pregnancy that occupied the lower uterine segment. So here is the normal placenta from the amnion side. You should ask yourself, how do I know that that's the amnion side? And immediately you should answer, I see the umbilical cord attaching to it, so it should be inside the amniotic sac. And this is the mole that was growing inside the uterus. In many cases of molar pregnancy, the ovaries contain multiple theca lutein cysts thought to result from the overstimulation of lutein elements by large amounts of chorionic gonadotropin secreted by the proliferating trophoblast tissue. And then we see the enlarged ovaries. So these are the ovaries, of course, still within the abdomen of this individual, filled with cysts that developed from overstimulation by the chorionic gonadotropin from those trophoblast cells that produce the mole. And the The source is given for this particular case. So the uterine bleeding is the most common sign found in these molar pregnancies and may vary from spotting to profuse hemorrhage. Uterus often enlarges more rapidly than expected for the known gestational age, so it seems to be an abnormally rapid rate of increase in size of the belly for the individual, and that's because there is an abnormally rapid development of the trophoblast cells forming the mole. There is typically a hypertension that's rarely seen before the 24th weeks as typical of a normal pregnancy, but there is an occasion with an early severe onset of preeclampsia with these molar pregnancies, and of course there's a significant extension, if you will, of the morning sickness. The greatest diagnostic accuracy is from the characteristic appearance on the ultrasound, which we started with. Treatment usually consists of immediate evacuation of the mole and subsequent follow-up for detection of a persistent trophoblastic proliferation or a malignant change. So all of this proliferating tissue must be removed and completely, and it has to be validated over time because it can continue to grow. And a follow-up evaluation for metastatic disease prior to treatment is important. Well, after treatment with suction evacuation or hysterectomy, if it's really severe, follow-up includes the pregnancy prevention for a minimum of a year and following serial measurements of the HCG levels. If HCG levels persist, then you know there are still some of these trophoblastic cells present producing it. If they plateau or rise, chemotherapy has to be given, such as methotrexate. So a rather extensive case, but it makes the point that other than struggling to read the ultrasound, most of it we can make sense of and understand. So it's a good sign that we're understanding things at that level. Might not be able to repeat it, but we certainly can understand it. So that's our part of our goal is to have that degree of interface at the higher disciplinary level in embryology. So the fetal surface we saw is characterized by the presence of the umbilical cord. So it's quite smooth from the amnion side. We have the attachment of the cord is usually at the center. It may attach at different places or to the fetal membranes. There's a typical cord length of about 50 centimeters. If it's too long, then prolapse can cause fetal hypoxia or wrapping around the extremities. So there are risks. If it becomes compressed, it decreases blood flow. And that's the hypoxia part of it. It may wrap around the neck, and it wouldn't cause hypoxia, whole body hypoxia, unless the cord was compressed and circulation decreased. It certainly can cause strangulation of basically any structure, even an extremity, and cause problems, slower growth rate, and even amputation. So if it's too short, then there can be a premature placental separation just from the torsions of the moving fetus, and become tied in a knot, causing fetal hypoxia as well. Whatever might compress it and decrease the blood flow can potentially cause a hypoxic insult or persistent hypoxic condition for the fetus. The amniotic fluid, we've reflected on it up to this point. We realize that it's extracellular fluid, some different contributions to it, and that it is recycling through the system. It's mostly that interstitial fluid. Endometrial lining contributes to it, and the blood in the intervillous spaces. So it's extracellular fluid of maternal origin as well. Some fluid from the amnion cells, the fetal lungs, and the fetal urine. So it's circulating through the embryo, the fetus and the embryo at the early stages, but definitely later fetus will start to undergo chest movements and move the amniotic fluid in and out of the lungs and constantly be swallowing it, and it's passing through the digestive tract. And, of course, any fluid swallowed and absorbed on that end is contributing to the urine production and recycling as the urine would go into the amniotic fluid directly. It's water, proteins, electrolytes, carbohydrates, lipids, all in varying amounts. So it really is representative of extracellular fluid. Couldn't be just the urine or what would be passing through the digestive tract, because you'd be less likely to find proteins in that. The composition changes over time, so that fetal cells will be included, more significant amounts of urine, and the dark tar-like, very gooey feces of the fetus called meconium. The continuous flux into and out of creates that balance with the fetal circulation. So it is a balanced recycling process. It exchanges fluids through the skin as well, the respiratory and the digestive systems, and all the extraembryonic membranes. So there is a vast interstitial fluid exchange, maternal and fetal. So what are some of the functions? Obviously, support, promotion of a symmetrical growth, so there's reduced chance or risk of compression. Temperature control, so water holds heat and doesn't dissipate it all that readily. So it is a good thermal structure in that sense. Promotes thermal stability, which is, of course, why if you fall into cold water, you'll go into a very stable state of hypothermia as it sucks all the heat out of you. So I don't want to misinterpret or misrepresent what it's actually doing, but once it has the body temperature within it, it's more likely to hold it. With all this exchange of fluids, maternal and fetal, there is a significant contribution to homeostasis, electrolyte, protein, carbohydrate, all those components we talked about. And it facilitates the muscular development and lung development. So the movement of the rib cage and the diaphragm and all of the swallowing reflexes and the internal reflexes of the GI system. So all of those are activated and act upon the amniotic fluid that is passing through. And then as well, of course, it's one opportunity to hold back any type of infectious agent, at least temporarily. So a breaking of the water or premature rupture is most common cause of the premature deliveries. So it's essential to sustain this amniotic fluid. If it is lost, then there are significant risks to the fetus, so delivery should ensue. So we see the blue membrane is the amnion, the smooth chorion, and the decidua capsularis is present here. We see it proceeding toward closing over the internal os in week 10. So that completes lecture 13. Let's then take a few minutes to talk about multiple births. So as an overview, there is an increased morbidity and mortality as the number of fetuses increases. So morbidity is a risk to full normal type of function and structure. And then mortality, of course, is risk of death. Quite often, morbidity increases the risk of mortality, but it's not always true. So this is rather obvious, even though there's been some rather large numbers of births from a single pregnancy, up to 6 or 7. So sextuplets and septuplets. They are very small at birth, and typically a couple of them are really at high risk of morbidity and mortality. Quite often, some may die. In some cases, the physician, the obstetrician, will inform a mother, the parents, of multiple pregnancies such as this, and offer the opportunity for a procedure called fetal reduction to reduce the risks of morbidity and mortality. It would be a very, very difficult situation to be in, where there are 7 developing fetuses, and you have to choose to leave 3 or some number behind, meaning that all the remainders have to be terminated internally without disrupting the entire pregnancy. So this is very, actually a more common situation, as we are all aware of, because we've all heard something about it, but it certainly is a very challenging and painful type of decision-making process to have to deal with it, including saying no and then having 7 kids, boom, automatically. That's got to have a little pain beyond the labor and delivery all the rest of your life, I guess. So the more common occurrence now, as we said, because of certain types of hormone treatments to bolster ovulation and, of course, the in vitro fertilization, but there are multiple zygotes implanted with the hopes that at least one will persist and survive. So the frequency of twins is 1 out of 85, triplets 1 out of 90 squared, 8,100. Quadruplets, it continues to add on quadruplets, quintuplets. The power is to the number of zygotes produced. So a dizygotic can be a condition of twins that we can talk about most familiarly and provide some clarification on terminology. So a dizygotic twin is the fraternal type. It originates from 2 separate zygotes, so they are not genetically identical. So the fraternal type of twins are 2 separate zygotes, 2 separate ova, 2 separate sperm, completely distinctive as far as genetic distinctions can be discriminated in siblings, 2 genetically distinct individuals. So this is about 2/3 of the cases of the twins. The rate increases with maternal age, more common in blacks and in Caucasians than in Asians. So there is difference among ethnic groups. Families show genetic predisposition to twins, and you always have 2 amnions and 2 chorions, but you may have either 1 fused or 2 separate placentas. So each embryo and fetus will develop its own amnion, its own chorion, but the placenta, the overall collective placenta, can vary. Let's follow through with this, looking at figure 727. So with 2 separate zygotes, there can be an event that would occur at the 2-cell stage where they would split and each would become excuse me. Sorry about that. We have two zygotes, zygote 1, zygote 2, each going on to develop into its own blastocyst. And the blastocyst will implant, and so there are obviously dizygotic twins, two zygotes. When they are undergoing the development, in this case they're rather close to each other, the placentas can be implanted very nearby. In this case, we're seeing separate placenta where we zoom in. There is no connection between them whatsoever. The syncytiotrophoblasts, the cytotrophoblast layers, the villi, there's no connection between the two. And they each have their separate chorion. Here's another case, same thing, dizygotic. But this differs in that we end up with them implanting close to each other, and the chorionic sacs will fuse. They're each going to have their own separate amnion, but they'll have a fused chorion, and when we look, there will be fusion of the chorions through the syncytiotrophoblaст cell layer. Note that there's no sharing in the circulation in this case, just a fusion of the chorion. So what are the frequency of the types of placentas in the fetal membranes in the monozygotic and the dizygotic twins? So obviously the monozygotic twin is the one that I began to describe there with one zygote and the typically, well, one of the blastocysts, the blastomeres will break off and develop into a complete embryo and fetus. So there's a splitting or a separation of the cells, those blastomeres, very early on. So the zygosity is shown here on the left column of this table, monozygotic and dizygotic, and the type of chorion, single or two. So with monozygotic, a single amnion is very rare. With dizygotic, it doesn't happen. With two amnions, there's a 65% chance in monozygotes. And we see the fusion can occur in monozygotes, 25%, with two placentas, 10%. So we're more likely to have fused, a single placenta in the monozygotic case. So, which has the highest frequency of single chorion and two amnions? Let's take a look at this. Single chorion. So the 10% would have two, so 90% would not. So that is the highest frequency of a single chorion. And two amnions, 65% are likely to have it. So the monozygotic twins are more likely to have, more than 50% of the time, should have two amnions and are very unlikely to have the two placentas, a single chorion, which has the highest frequency of two chorions and two placentas. So that would be the dizygotic because it has both the higher percentage in each case to have the two chorions and the two placentas. So continue on with this discussion then. The most common types of twin formation and characterize the relationship of placentas and fetal membranes of the twins. So we have Nayeli with us in the classroom here today. So part of her task, in addition to typing in questions that I've generated, will be over time to take these types of organized statements to generate questions. And I remind everyone that that is the approach, that's the reasoning behind posting these this way. You should try to imagine how this could be turned into some type of a question. It could end up being several questions, of course. So monozygotic or the identical with the separate placenta, amnion and chorion, or a common placenta and chorion and a separate amniotic cavity. So separate amnions is a consistent thing that we're seeing. However, here we see the third instance of common placenta, chorion, and amniotic cavity. So it's not always a dedicated single amniotic cavity. It is possible. So dizygotic or fraternal twins will have separate placenta, separate chorion, and separate amnion, or separate placenta and amnion and a fused chorion. The dizygotic twins will always have their own amnion. So in the case of the monozygotic twins, where a blastomere somehow breaks away and becomes dedicated to produce a separate embryo and fetus, there is the possibility that it can get within the same amnion as the other twin. So now we can spend a bit of time delineating this monozygotic condition or the identical twin. So it's a single zygote, and the infants are truly genetically identical, so 100% genetically identical. So they could never be distinguished through their genes unless one wore blue genes and one wore green genes. So it begins at the end of the week 1, resulting from the division of either the inner cell mass, so that's the more common one, or the morula, which is less common, into the 2 embryos. So one of those early blastomeres, or a set of those early blastomeres, have to become committed separately. So here we can see the illustration making this point. So we look at a 2-cell embryo leading ultimately to 2 separate inner cell masses. So a division of the blastocyst after the trophoblast forms would lead to the 2 separate amnions, the 2 separate embryos and yolk sacs, and a single placenta. So the produces twins that share the same placenta. Or in another instance where the division of the blastocyst occurs prior to the formation of the trophoblast, then you end up with 2 separate blastocysts, and they will develop into 2 separate placentas, chorions, of course, and the amnion, as well as the yolk sac. So there'd be separate placentas in this case. The division of the blastocyst prior to formation of the trophoblast produces, so prior to the formation of the trophoblast is going to produce this lineage here. So let's see if we can pick it out. Dizygotic, cancel that one, monozygotic, 1 chorion, 2 amnions, nope. Monozygotic with 2 chorions and 1 amnion, nope. Monozygotic with 2 chorions and 2 placentas. This is what we see. 2 chorions, 2 placentas. So this drawing now is going to take us through the illustration of how about 65% of the monozygotic twins develop from the 1 zygote by division of the inner cell mass of the blastocyst. And these have the separate amnions, single chorionic sac, and a common placenta. So this was the second case if the blastocyst separates after the trophoblast has formed. So we see that case here with 2 inner cell masses. Within the same blastocyst cavity, we're going to produce the 2 embryo discs. And so we see the case of 1 placenta, 2 chorionic sacs. So there's no fusion of the chorion, and the 2 amniotic sacs. Or the other instance where it would be, as shown here, with the 2 amniotic sacs and the shared chorion, in this case with no junction of the vasculature. In the lower case, an anastomosis of the placental vessels and an arteriovenous communication between the circulatory systems of the twins. So this is not always a good situation when there is a sharing of the circulation. Here is figure 729 from the text showing monozygotic, monochorionic, diamniotic twins, showing a wide discrepancy in size. Obviously, this one's teeny tiny, and the little girl over here is a bit bigger. Got a little more of the blood supply, seems like. So this resulted from an uncompensated arteriovenous anastomosis of the placental vessels. So the blood was shunted from the smaller twin to the larger, producing the fetal transfusion syndrome. So we'll stop at this slide, and since we're at the 10-minute till, and we'll pick up from there on Wednesday. Hope you all have a nice afternoon. So recall that Marco reactivated the exam 1 for everyone. So you still have that one additional time to take it. I haven't checked out the WebCT, but hopefully if anyone had troubles, again, if you're logged on using a phone line or anything like that, and you get disconnected, your time is still ticking, and the software doesn't fix it for you, so you need to notify us so that we can take care of that. So I'll remain here for just a minute if there are any questions, and then I've got to buzz off to the Health Science Center.
Dr. Felix.
Hello?
It's me, Nayeli. I have a couple of questions about the upcoming test.
Yes. Hear me?
Yes, sir. Natalie's got a couple questions for you. She's going to use the mic up here.
Yeah, sounds good.
Okay, Dr. Felix. The first few questions, you just have like slide 1, slide 2, and slide 3 as the question. I mean, am I supposed to put anything in place of that?
I will be locating the image files that go with that.
Uh-huh.
And after you've got these typed in and saved,
Right.
and I'll link them to the image.
Oh, okay. So you just want me to go ahead and put it as it is as you wrote it down?
So once you've got the questions, have you clicked on the buttons and found how to add questions to the question database?
Mm-hmm. Wait, what did you want me to do?
Have you had the opportunity to click on the buttons in there in WebCT to enter questions in the exam? I'll switch to the desktop, and then you can see it as I do it here.
Yeah, that's the stuff I showed you how to do.
Oh, okay.
And how to add the questions to the database and then upload that.
There's also a problem with my ID user. It doesn't have me as a designer. So I have to talk to WebCT. As far as I know, I can't input anything right now.
They had, I thought you were...
Right.
Yeah, I thought so too, but apparently she's only a TA and doesn't have actual designer access.
I think you were both designers at first, and then when I went on and added you as TAs, it eliminated that other function.
Oh, okay.
So, yeah, let's work with WebCT to get you switched over.
Okay. All right, so I should just leave it as it is, as you wrote it down?
And are you just typing them in?
Either that, or if WebCT says that I can have a disk and just automatically download it, then I'll do it that way.
Yeah,
the format it'd take you hours to convert a Microsoft Word file into the format for uploading the question.
Oh, okay. So I just type it in.
Yeah, that's right. Well, I do it. Here we did the database for exam 2 yet. And I don't know if the database structure that I've been creating is necessarily the best one. I just made a database of questions for each exam, and it looks like you have started, right?
Yeah, we tested a couple of them manually, typing them in, but there's an option on the side that says import questions from file. I mean, does that do that automatically from
Well, what you want to do is download the set that you've got in there and see all the entries that have to be made in there. The code is really just a pain.
Okay.
And so once I get the image uploaded, you just click on this browse, and that's how you link it to an image.
Okay.
If it was one of these, you'd pick it and then click on it and then hit the pick.
Just trying to get no image.
I lost your image. I hear you, though.
What's that, sir?
Lost your picture. Up to the overhead. That's camera again, or teacher for yours.
Is that what you wanted?
Yeah. It suddenly went to the Elmo, and then it went black. I lost you.
Oh, yes, I was just trying to get the exam questions off the projector.
Oh, okay.
He was messing with it.
Since there's still students here.